Hi, welcome to Complex Coronary Interventions from the Leeds General Infirmary. This is a case of a circumflex coronary artery conduit occlusion, treated retrograde via an occluded graft. This was a case of a 74-year-old man who had undergone previous coronary artery bypass surgery and presented with recurrence of angina. He had documented lateral ischemia on perfusion imaging. His angiogram showed severe stenosis in the vein graft of the circumflex coronary artery. At the District General Hospital, an attempt was made to perform PCI, but they were unable to fully expand the lesion and unable to pass the stent. So he was referred for CTO PCI to treat the native circumflex coronary artery. So these are the diagnostic images. This is the native circumflex showing the stump of the occluded obtuse margin here. It's a good sized vessel with some disease of the ostium of the circumflex extending to the left main stem. This is the vein graft showing degenerative diffuse disease with a severe calcified stenosis in the mid graft. You can see here some flow back into the proximal circumflex with a good sized distal territory. This is the patent Lima 2 LAD, and this is the patent graft to distal right coronary artery. A brief attempt was made to perform PCI, but due to calcification, they were unable to pass the devices or open the vessel. So the patient was referred for CTO PCI. It was then a surprise to find that in fact the vein graft had occluded in the interval period, having had attempted PCI around 6 weeks earlier. The patient's symptoms had actually deteriorated in these 6 weeks, consistent with this finding. So the challenge was now to try and recanalize the occluded graft and use this as a retrograde conduit. So this is a 7 French AO1 guide catheter from the left radial, and this is a turnpike helping micro catheter and a pilot 200 wire. And a pilot 200 wire is actually a very good wire for crossing these graft occlusion, and in my experience it is usually possible to cross occluded grafts which are less than 1 year old, which have been occluded for less than a year, and even sometimes I have managed to open or at least cross grafts which have been occluded for up to 2 years. So here pilot 200 has made some progress to the distal portion of the graft using the roadmap from the diagnostic procedure. I was confident that we were in the graft and nearing the anastomosis of the distal vessel. And again, with some wiring here, the pilot 200 frees up and is now into the distal native obtuse marginal. So with the wire distal, the plan is, with these cases, the key is to try and deliver a guide extension catheter, which are crucial for these types of graft cases, particularly when trying to go retrograde for support. So here we take a balloon and sequentially dilate to try and deliver a 7 French guide extension, in this case a guide liner. I find that a long balloon is helpful as this provides a longer rail to deliver your guide extension. So here this is initially a 2530 balloon, and this is what we call an inchworming technique, where you dilate the balloon and advance the guide extension onto the balloon, and as you deflate, you try and advance your guide extension over that balloon, and you keep repeating this process down the vessel as we are here. Again, dilating a bit more distal, pulling on the balloon to try and bring the extension catheter in, and then as the balloon deflates, sliding the guide extension over the balloon. Here we are again. We've made some progress now, a bit more distal. With the balloon up, we can reposition everything, reposition the guide extension, and slowly we are making our way down the graft. So here we're able to cross the tight lesion and now deliver the guide extension. And then we introduced the turnpike LP and did a tip injection here to clarify the distal anatomy. Now, we normally avoid tip injections where we are not clear if we're in true vessel architecture or not, but here I was fairly confident that we were, and here the reason for the tip injection was not to confirm whether we were in true vessel or not. It was really more to define the anatomy and try and clarify the course back up the proximal vessel, proximal to the anastomosis, so that we could recanalize the vessel. And here you can see there's a faint channel probably here, going back up to the circumflex. So this provides a roadmap of where to try and wire. And so we then took this is a cyan black wire, and managed to find the course back up the obtuse marginal, and then the turnpike is successfully delivered around the bend, which can sometimes be difficult to do, and occasionally you need to do maneuvers such as having a blocking balloon distally, just distal to the anastomosis, so that the turnpike or the microcatheter can make the turn. Other tricks to try and overcome such acute angulations are to use angled microcatheters such as the Supercross 120. Here, having managed to get into proximal circumflex, the aim now is to blunt dissect to the proximal cap, and we do this using a knuckling technique. So this is a pilot 200 wire folded over, accessing likely the subintimal plane and being pushed safely in the subintimal space. This is a much safer way of crossing ambiguous anatomy rather than trying to wire with stiff wires. So we then take a picture from the antegrade guide catheter to clarify where we are. And we can see that we are at the proximal cap of the occlusion. So using this then as a marker, we then used a twin pass dual lumen microcatheter to try and puncture this angled proximal cap. And the dual lumen catheter allows you support to try and puncture these types of caps, which can be difficult, especially when near flush occlusion, where it's difficult to get support with a standard microcatheter. And so here we are. We have managed to direct a wire into the proximal cap. This was a Gladius wire by Asahi, which is essentially a steerable form of the Pilot 200 wire with the Asahi Act 1 technology. And here you can see the antegrade wire is now overlapping the retrograde equipment, and try and push it on to try and form a knuckle, so that we are hopefully in the same space as the retrograde equipment. We then remove the twin pass, trap this off using a trapping balloon, and then introduce a microcatheter. Here, for support purposes, I have inflated a balloon distal to the branch for dual purpose. One is to act as an anchor, and second to act as a blocking balloon to allow the microcatheter more support and angle into the proximal cap. So finally, the microcatheter is able to cross. And able to push the wire on to form a knuckle, clearly overlying with the retrograde equipment, and now we are set up in a good position to perform reverse cart. So here we are setting up for reverse cart, introducing a balloon with a guide extension catheter, and the aim is to inflate the balloon to enlarge the communication and connect the antegrade equipment to the retrograde equipment, and then to wire the space produced by the balloon from the retrograde side. So here the balloon is inflated. And in fact, we lost our wire position, antegrade, but having produced the communication, I tried to access that with a soft polymer coated wire. This is an XTA wire, which actually finds the path and able to wire out into the aorta. So now there are two options. One is to try and wire the guide catheter, or to deliver your microcatheter and to then deliver a long wire for snaring. In the first instance, I attempted just to take the guide extension back and try to wire this. And in fact, it was fairly straightforward here. As you can see, I was able to successfully wire the antegrade guide extension and into the antegrade guide. The wire is then trapped with a balloon, and with the balloon inflated, the retrograde turnpike LP is slowly advanced into the guide. With the wire trapped, the next step is to perform externalization of a long wire, and we tend to use the RG3 wire. There are alternatives such as the R350. So then the retrograde fielder XT wire is removed, and here I am trying to pass the RG3 wire. So here it comes up the vein graft into the antegrade guide, but there is a lot of friction at this stage, and it is not possible to push the wire on. And this is likely due to all the angulations that you can see in this image from the guide catheter, the graft itself, the anastomosis. So the next option is one of the options is to perform a tip-in maneuver. This is what I did. So here is where you try and wire the retrograde microcatheter with an antegrade wire, and then pass this through the microcatheter through the occlusion into the vein graft. So here we are. This is usually best performed at an angulated segment of the guide catheter at the apex, so you can direct both bits of equipment to roughly the same place. So this is real time. See here, trying a different position now. I've taken the microcatheter back, trying to wire, and then so here they're lined up, and then I've just advanced the retrograde microcatheter. And in fact, the retrograde microcatheter here has gone over the wire itself. So you can see here the wire is now in the microcatheter. This is a cyan black wire. And then simply advance the wire through the body of the microcatheter into the graft. And you can advance the wire a fair good distance to give you support, and actually you can maintain adequate support from this technique as compared to having an externalized wire, which is the best form of support. So with the wire advanced far up the body of the microcatheter, retrograde microcatheter, the retrograde turnpike LP is then slowly removed, and at the same time follow this with the antegrade microcatheter, which was a regular turnpike here. And you are able to torque the antegrade turnpike all the way around, following the retrograde microcatheter. We've now crossed the occluded segment. And at this point, I have chosen to try and wire the distal obtuse marginal from this point and successfully wired this with this iron black, as you can see. The turnpike catheter is then taken on into the obtuse marginal, and the wire is removed and exchanged for a standard workhorse wire, and in this case, the cyan blue. My catheter is then withdrawn. Pre-dilations performed. This was a 3 mm NC balloon. And again, trying the inch-1 technique, but still very difficult to deliver the extension device. So in this situation, we already have a wire from the vein graft into the distal obtuse marginal. So this allows us to introduce an anchor balloon. And so this is the balloon introduced from the vein graft, which is inflated, anchoring the antegrade wire from the native circumflex. And this then really improves the support. And here you can see with the balloon inflated, it is then possible to advance antegrade equipment, further preparation with a 3 mm Wolverine cutting balloon to prepare the lesion adequately. There's adequate expansion of the balloon. After preparation, a stent is delivered. The anchor balloon is deflated, and the stent is delivered to the distal vessel. Obviously, you must remember to remove the anchor balloon prior to deploying the stent. This is the first stent delivered through the occlusion into the obtuse marginal. This was a 275 28 mm stent. The inlet was post-dilated to high pressure with good expansion of the balloon. And this is a 3033. millimeter stent being delivered and deployed from the lesion into the proximal circumflex. And at this point, intravascular imaging was performed to size the left main stem as there was significant disease. At the proximal circumflex imaging, so it was decided to stent back to the left main ostium. So here, after imaging, a further stent is placed from the proximal circumflex to the ostium of the left main stem. This was a 3.5/23 millimeter stent. This initial picture showing patent vessel now with flow into the distal circumflex. There is a hazy area at the area of the reverse cart, which is to be expected given there is dissection planes at this area. And this should heal nicely. Proximal optimization of the left main stem stent was performed with a 4.5 millimeter NC balloon sized on IVUS. So this is a 4.5 millimeter NC inflated at 20 atmospheres. The proximal LAD supplies a reasonable sized diagonal territory. So we elected to optimize this with opening the struts from the circumflex stent and to perform kissing inflations of the LAD and circumflex. So the circumflex is dilated further. So plan to perform kissing inflations with the LAD to open the struts. So this was with a cyan blue wire. And the circumflex, proximal circumflex was post-dilated with a 3.5 millimeter NC balloon, and using this as an anchor balloon, we advanced a 3.5 millimeter NC balloon into the ostium of the LAD. And you can see that this went fairly easily. proximal AT was dilated, and struts were opened. And finally, casing inflations were performed. Give some integrated nitrate, and here's the final result, showing excellent TIMI3 flow into all branches and a patent circumflex. There is some haziness around the dissection area, but this should heal nicely. Thank you for joining us for this case presentation.